Welcome to This Week in Ophthalmology. This week we're covering 10 notable papers spanning intravitreal drug choice and safety, the systemic disease that hides behind ocular findings, and new data on myopia control, geographic atrophy phenotyping, and surgical technique. Let's dive in. We start with medical retina, where two papers ask different questions about the same crowded injection cabinet. In the British Journal of Ophthalmology, Liu and colleagues report a systematic review and frequentist network meta-analysis comparing high-dose aflibercept, 8 mg, against faricimab for macular edema from retinal vein occlusion, using 4-weekly aflibercept 2 mg as the common comparator across 3 trials and just over 2,000 adults. There were no head-to-head trials, so everything here is indirect. Mean visual acuity gain did not differ between the agents. What did differ were the details clinicians actually negotiate with patients. 8-weekly high-dose aflibercept after 5 monthly loading doses was about 18% more likely to get an eye to the 20/40 driving threshold than 4-weekly faricimab. Faricimab, in turn, achieved complete resolution of intraretinal and subretinal fluid about 12% more often. And on safety, both aflibercept regimens carried a higher risk of a clinically significant pressure spike in the half-hour after injection, with the high-dose regimens showing something on the order of a 6 to 7-fold greater risk than faricimab, though the estimates are imprecise. The practical read is that these agents are broadly equivalent for vision, and your choice should turn on whether you are chasing a dry macula, chasing a driving standard, or protecting a compromised optic nerve from post-injection pressure. That safety thread continues in retina, where Chablani and colleagues interrogated the United States Food and Drug Administration Adverse Event Reporting System for retinal vasculitis events linked to intravitreal anti-VEGF agents and complement inhibitors. Between 2020 and 2025, they identified 554 reports attributable to a single agent, with reporting clearly rising after 2019. Brolucizumab dominated at just over half of all reports, followed by faricimab at about 1 in 6, pegcetacoplan at roughly 1 in 8, and much smaller shares for the aflibercept and ranibizumab products. Only one report involved an aflibercept biosimilar, and none involved a ranibizumab biosimilar. The authors are appropriately blunt about the ceiling on these data. Spontaneous reporting cannot establish incidence, causality, or comparative risk, and reporting itself is shaped by publicity and litigation. Read alongside the network meta-analysis. The message is that comparative safety in this space remains genuinely unresolved, and that consenting patients for complement inhibition or newer bispecific therapy should include intraocular inflammation as a real, if unquantified, possibility. The second theme is the eye as a window onto systemic disease and systemic drugs. In retina, Hayat and colleagues followed 190 consecutive patients with central, branch, or cilioretinal artery occlusion for a median of just over 2 years. Major adverse cardiovascular and cerebrovascular events occurred in about 14% of patients, and critically, roughly a quarter of those events happened within the first month after the occlusion. Hyperlipidemia independently tripled the risk in both logistic and Cox models. Central occlusions carried higher risk than branch or cilioretinal events, though that reached significance in only one model. Visual outcome was driven by baseline acuity and age. Eyes treated with hyperbaric oxygen improved within group, but final acuity did not differ significantly from untreated eyes, so this is not evidence of benefit. The actionable point is unchanged and worth repeating to every trainee. Retinal artery occlusion is a stroke equivalent requiring same-day systemic workup, and lipid management is the modifiable lever. On the pharmacological side, also in the British Journal of Ophthalmology, Oliver and colleagues used the TriNet-X international database to examine fenofibrate in patients with diabetes and mild or moderate non-proliferative retinopathy, propensity matching roughly 4,000 fenofibrate users against non-users for each outcome. Fenofibrate use was associated with roughly half the odds of progressing to vision-threatening retinopathy, around 40% lower odds of developing cataract, and about a 2/3 reduction in the odds of developing diabetic macular edema. Primary open-angle glaucoma showed no significant association. This is retrospective claims-based work with all the confounding by indication that implies, but it aligns directionally with the randomized fenofibrate retinopathy data and strengthens the case for asking your endocrinology and primary care colleagues about phenofibrate in patients with early retinopathy. Still in the British Journal of Ophthalmology, Chen and colleagues analyzed nearly 500,000 UK biobank participants and found that glaucoma was associated with roughly 3 times the odds of cataract, after adjusting for demographics, comorbidities, and ocular parameters. Topical treatment carried similar odds, but participants who had undergone glaucoma surgery had about 12 times the odds of cataract. This is cross-sectional, so causal direction and surveillance bias are genuine problems, and the laser subgroup was too small to estimate reliably. Still, it quantifies what glaucoma surgeons already counsel. Filtering surgery accelerates lens opacity, and these patients need earlier and more structured cataract surveillance. Our third theme is phenotyping and prognostication. In the American Journal of Ophthalmology, DeCarlo Forrest and colleagues prospectively followed 81 eyes from 48 patients in a Colorado age-related macular degeneration registry, each with at least 5 fundus autofluorescence time points, using artificial intelligence segmentation with specialist review to model geographic atrophy growth. They describe 3 candidate phenotypes: unifocal foveal involving, large coalescing multifocal, and small numerous multifocal. Both multifocal phenotypes had more severe growth trajectories and larger projected maximum lesion sizes than the unifocal foveal involving pattern. And eyes with a peripupillary component grew faster and were projected to reach larger final sizes. The sample is small and single center, but in an era where complement inhibitors are judged on lesion growth rate, baseline phenotype could be a meaningful source of imbalance in trials and a useful prognostic signal in clinic. That sits naturally alongside a narrative review in Retina from Iglicki and colleagues, which synthesizes the optical coherence tomography and angiography biomarker literature, disorganization of the retinal inner layers, hyperreflective foci, fluid compartment patterns, perfusion change, into a framework for distinguishing angiogenic from inflammatory disease and for timing surgery in tractional maculopathy. It is a review, not new evidence, but it is a useful organizing structure for how many of us already read a scan. Ophthalmology brings a phenotyping paper from the neuro-ophthalmic side. Batista and colleagues describe 77 patients with late-onset Leber hereditary optic neuropathy, meaning onset at or after age 40, drawn from a larger Italian cohort of 398. The M.11778 G-to-A variant predominated. The male predominance was less pronounced than in classic disease. Close to 60% of patients had a smoking history, and more than 4 in 5 affected women were postmenopausal. Overall visual recovery was just under 40%, and an exploratory decision tree analysis linked recovery to idebenone at 900 mg a day or higher, and to J or T mitochondrial haplogroups. These are hypothesis-generating associations from a retrospective cohort, not treatment evidence, but they support asking about smoking and hormonal status in later life optic neuropathy, and not dismissing the diagnosis on age alone. Finally, 2 papers about what we put in front of and inside the eye. In JAMA Ophthalmology, Shen and colleagues report the 24-month results of a double-masked randomized trial of spectacle lenses with highly aspherical lenslets versus single-vision lenses in 159 United States children aged 6 to 12 across 9 sites, with about 85% completing follow-up. Myopia progression was reduced by roughly 70% in relative terms, a difference of about 2/3 of a dioptre over 2 years, and axial elongation was cut by roughly half, a difference of about 1/4 of a millimeter. Best corrected acuity was equivalent, ocular adverse events were similar between groups and none were lens-related, and symptom reports were, if anything, fewer in the treated group. This is the trial underpinning Food and Drug Administration authorization of the device, and it extends efficacy previously shown mainly in Asian cohorts to a United States population. And in Retina, Cho and colleagues compared transscleral 4-point fixation using a closed continuous loop suture against the Yamane technique across 179 eyes. Visual and refractive outcomes at 6 months were comparable, and complication rates, including corneal decompensation, hypotony, and endophthalmitis, did not differ. Yamane was about 14 minutes faster but carried a substantially higher hazard of lens redislocation, with a point estimate around 8-fold and a very wide range around it given few events. Speed versus durability. and the authors argue preoperative structural assessment should drive that choice. If you only have time for one paper this week, make it the JAMA Ophthalmology trial of highly aspherical lenslet spectacles in United States children. It is a randomized, double-masked, regulator-grade result in a population where these lenses were previously unproven, and it changes what you can offer a myopic child at the next visit. Here are the key takeaways from this week in ophthalmology. First, highly aspherical lenslet spectacles substantially slowed myopia progression and axial elongation in United States children over 2 years with no safety signal. Second, high-dose aflibercept and faricimab give similar visual gains in vein occlusion edema. Pick on drying, driving vision, or post-injection pressure risk. And remember, all these agents carry retinal vasculitis reports in pharmacovigilance data. Third, treat every retinal artery occlusion as an acute systemic emergency, with the highest event risk in the first month, and hyperlipidemia as the strongest modifiable predictor. Fourth, fenofibrate in early diabetic retinopathy is associated with less progression, less macular edema, and less cataract, worth a conversation with the prescribing physician. And fifth, both glaucoma and especially glaucoma surgery are strongly associated with cataract, and geographic atrophy phenotype on autofluorescence predicts how fast the lesion will grow. That's your roundup for this week in ophthalmology. The full transcript and references are available on the episode page in your Audio Scholar library. This is an AI-curated summary. For clinical decisions, always consult primary sources and current guidelines. See you next week. If this weekly briefing is useful, follow the show in your podcast app so new episodes arrive automatically. And a quick rating on Apple Podcasts or Spotify helps other physicians discover the show. This is an automated summary generated by artificial intelligence, which can make mistakes. Always review the original source materials.